Yes, I'm in the Pacific time zone. It's pretty early for me, so any mistakes you can attribute it to sleep deprivation. So thank you very much for having. This is just, I have no conflicts of interest to disclose. Next. So let's get started with talking about what early detection means, especially in this era where we have emerging therapeutics, which are highly debatable these days. But we have emerging therapeutics and diagnostic technologies that enable us to find pathologies before there's any cognitive impairment. We're not talking about that here. We're talking about a clinical level of early detection of dementia itself, not of the pathologies that may underlie it. So early detection of dementia means, for our purposes, recognizing cognitive impairment when it's there and when it's impairing everyday function, and preferably before a crisis occurs. Most of you know that people with dementia often present after several years of decline. Takes that long oftentimes for family members to understand that changes that they're seeing actually are part of a process that needs to be reported to a clinician and better understood and planned for. Detection of cognitive impairment is different from diagnostic evaluation for a specific cause or disease. We're looking for a signal in the first instance. We want to know, is there a signal that cognitive impairment of a clinically important level is present? Next slide. Let's talk about why it matters. This has been one of the hardest points to convince people of. Keep going with this one. This is an animated slide. Why does it matter? Because with progression, dementia becomes a dominant condition. What does that mean? It becomes an organizing principle of care. Everything about the way we care for people with dementia eventually is influenced by the dementia itself. We need to tailor our approach to it. So it affects not only the person, as we all know, but the family and their friends, social network, neighborhoods, communities, and ultimately the larger society. Next, please. Dementia also increases risk to health and safety in many different kinds of ways. Next, please. And it changes the context of healthcare. That's because patients gradually lose agency, the ability to make autonomous decisions, to anticipate what's next, to plan their lives, and to carry out intentions. So family and friend partners become healthcare managers at home. I want to focus for just a moment on that idea of being a healthcare manager at home. We think of caregivers and managing behavioral issues and so forth, but actually one of the crucial functions of care partners is that they become the agent of all the rest of the care. So what social care, healthcare, medical care, medications, monitoring health conditions, all of these things are health management tasks that care partners need to become adept at and often have a lot of difficulty with. Next, please. And finally, we can't manage what we can't see. If we don't know that our patient has cognitive impairment, we're likely to just add that third antihypertensive drug when the blood pressure is high, which then results finally when daughter takes over and gives all three meds, the patient becomes hypotensive and falls and ends up in the emergency room. These events are rare, but you never forget them. So we want to see that dementia is present so that we can accommodate to it in the way we approach the patient, the family, and others. I realize that many of you are not physicians or nurses, and that you don't use the terminology patient. So I ask your indulgence. As a physician, I'm just in the habit of referring to the people I work with as my patients. I'll try to be. They're not, that's the best designation for them as individuals who are suffering a condition that I'm trying to help with. So please indulge my use of language. Next, please. And next. So to drive the point home, dementia affects all aspects of healthcare. If you keep going, you'll see step by step, all the different ways that we know from data dementia affects care. Misdiagnoses, unnecessary crises, accidents and injuries, medication mistakes, caregiver stress and poor health as a result of that, family breakdown, inappropriate treatment choices, poor chronic disease control, discontinuities in care, preventable hospitalizations, complications during hospitalization, such as delirium or falls, and high readmission rates. Next, delirium, of course. Next, surgical complications have received a lot of attention as a result of dementia in recent years, and the various US surgical organizations are now recommending cognitive screening for all older adults before they undergo surgery. More on that later. Next. So is dementia evaluation important? So here we're talking about an evaluation of the patient for dementia. That's beyond screening. This is really about the process of trying to understand what's going on with a person who has cognitive impairment. We've already detected it. Now we need to evaluate it. Is it important to do that? Here's what clinicians and families say in a study done in France. Next, please. Early and timely diagnosis does mean a chance to think ahead and reduce complications and crises if you manage them. A chance to manage symptoms, to reduce their severity, to support quality of life, and provide continuity of care and support for everyone concerned with the person. Next. This study was done with an online survey using a standardized questionnaire about perceived benefits and risks of diagnosing dementia. Next. It presented 4 case scenarios: mild cognitive impairment. This was isolated, in this case, isolated memory impairment, no other cognitive problems, with or without a complaint from the patient about their memory. Mild to moderate dementia, moderate to severe dementia with behavioral symptoms, and severe dementia with behavioral problems. So these were the 4 case scenarios that were presented to respondents in this survey. Next, please. 719 providers were included: general practitioners, cognitive disorder specialists such as geriatric psychiatrists, neurologists, and geriatricians, 281 other healthcare professionals such as speech therapists, and 79 family care partners. Next. Here was the list of benefits and risks that were studied in this investigation. So the investigators put together 8 potential benefits that a person has a right to know about their health conditions. They need this information to make decisions about their future care. Without detection, we can't offer drug therapies for symptoms that might be beneficial to help people function better in the moment. It also denies people the opportunity to use non-pharmacological therapies, various kinds of psychological interventions and activity interventions to improve quality of life. Proactive care planning and management, education about the disease and its likely course, support for care partner coping skills and teaching skills for care, and participating in clinical trials. These are the potential benefits of evaluation for dementia. Here are the risks. Sometimes normal aging changes may be treated as abnormal. That would be a mistake. Diagnostic uncertainty plagues this field still. Reaction to diagnosis. People worry that depression, anxiety, or suicide may happen. I'll speak about that for a minute now. So in the largest study ever of screening for dementia, depression and anxiety did not increase among people who had been screened. This was from Indiana University, led by Dr. Malaz Bustani. Just recently, however, there have been 2 publications about small increases in suicide risk among people who had recently received a dementia diagnosis. One was done in the VA system and one was done with Medicare claims. And both of them showed a small uptick in suicide after a person received a diagnosis for the first time of dementia. So that's not screening for dementia, mind you. This is the result of an evaluation. This is a diagnosis. So it remains to be seen what these data are all about. what's happening here. And I'll leave it at that because that's all we have in terms of the literature on suicide so far. We haven't seen this in other studies, probably because we haven't had large amounts of data to analyze. Remember, suicide in older people is a rare event. So when I say there's an increase, it's a significant increase, but the rate is still very, very low. Okay, what are some of the other risks of evaluation for dementia diagnosis? Could it have a negative impact on a relative? We don't have a disease-modifying treatment. Now, if you like in the conversation, we can talk about the recent approval of aducanumab, Aduhelm, but generally speaking, we haven't had disease-modifying treatments that alter the course of decline. Also, what if there's no access to diagnostic expertise? And what if there's no access to stage-specific services to help people with dementia? Why detect it if you can't help? And then stigma, always. Social isolation, rejection by one's friends, and the fragmentation of families. These things can happen. I would submit to you that mostly they are not actually the result of a diagnosis of dementia or of an evaluation. They and making better diagnoses helps to support the shoring up and development of more services. Next, please. So what did people say? Now, remember, these are clinicians dealing with individuals with this problem of, is it good to diagnose dementia or not? Next. Well, more than 80% of everybody said that detecting cognitive impairment and starting a workup was relevant at all stages of dementia, from mild cognitive impairment to the very end of the dementia course, severe dementia with bad behavioral problems. Next. The perceived benefits outweighed the risks for everybody at all stages. Next. And for mild cognitive impairment, that's mild memory loss, but without significant everyday functional impairment, not so many GPs and other health professionals thought a full workup was relevant. Specialists and care partners were more inclined to want to seek a full diagnostic workup. Next. And for severe dementia, fewer in all of these groups thought that it was relevant to do a full diagnostic evaluation. Less than half of GPs, around the same for specialists. Family care partners wanted more of this, but when we think about it, severe dementia is an end stage of disease, really, and so it remains questionable as to whether or not it makes much sense to go in depth into a diagnostic evaluation when we know what the course has been and what the future course is likely to be. Next, please. Keep going. Detection of dementia can happen anywhere. Next. So here's an example. This is taken from Dementia Friendly America. So this is just a part of their bank of information about how dementia impacts people within the community. But these also create opportunities for detecting dementia. The bank, the pharmacy, in faith communities, at a restaurant when people can't figure out what to choose or read a menu well, in retail establishments where people have difficulty making change, in the library where books might be forgotten. So you kind of get the idea that all of us can be responsible for detecting dementia. Where we fall down is we don't know what to do when we see it. Next, please. Diagnosis requires a healthcare professional. And so the notion of linking up community-based observations and organizations with healthcare systems becomes really appealing as a way of taking a public health approach to dementia detection. I'm not recommending that the bank manager call a doctor. I'm just saying that we need to be thinking broadly about the fact of how much dementia can affect transactions of all kinds in everyday life. And the fact that right now, we have no way to get that information to where it can make a difference in planning for the patient. Next, please. So who does own dementia? This is a question that's been asked for a long time. In healthcare, whose problem is it? Here we can see in the blue line, geriatric psychiatry, my discipline, we're not growing. You can see the line is quite flat. Geriatric medicine, there are more geriatricians than there are geriatric psychiatrists, but they too, their numbers are not growing. Hence we have the GWEPs to try to bring the expertise of specialists into the community of practice. In the solid red line, what you see is the trajectory of say, Alzheimer's disease. If you think of all dementias, all cognitive impairments, the rates are going to be a lot higher than this. But as we see, there's an exponential rise in the number of people with dementia, and that is because of aging of the population. Next, please. Well, who does this? Who has ownership of dementia right now? Let's take a look. Primary care providers. Next, they make 85% of first diagnoses. Yes. Next, 80% of ongoing care is provided in primary care for people with dementia. Next. And what do we know about it? Dementia is underdetected. At least 50% of cases are not detected in primary care. That's been true for the last multiple years. Next. Diagnosis tends to come late, and there are clear equity issues. People of color are less likely to be diagnosed at all. They are diagnosed later. When they are diagnosed, they're less likely to receive any kind of dementia-specific treatment. These are major concerns. Next. Diagnosis is often not otherwise specified. What does that mean? Well, it's a non-specific brain failure. And I like the concept of brain failure because it kind of like heart failure, it kind of brings you up and makes you take notice that dementia is kind of an abstract term, but brain failure brings it home. Next. There's also low uptake in primary care of benefits that can help dementia patients receive better care and are now paid for under Medicare. We'll talk about that. There's also inequities in the use of those benefits. Next. There's no reportable quality measure for dementia. This is something that is kind of shocking to me, but it's still true. There's no way to measure quality. There are some underutilized opportunities to do that, but there's no fully accepted and promoted standard for what dementia care ought to be. And that's a lot of the work that I've done over the years, moving in that direction. And it's the work of our Center on Early Detection of Dementia now. Next, please. What about memory disorder specialists, the neurologists, the geriatricians, the geriatric psychiatrists, neuropsychologists, and so forth? Next. They make 15% of first diagnoses. Next. And they provide less than 10% of ongoing care. Next. They do use more standardized assessment. Keep going. There's no person-centered comprehensive care model, though, that exists typically within the specialty world. Next. And there's no defined role or relationship with primary care in most healthcare systems. It's, take what you get rather than a planned, organized approach to supporting primary care. Next. Well, let's turn to screening. Should we screen older people for dementia? Next. It's important to detect dementia. Everybody agrees on that, from specialists to advocacy organizations to ordinary people every day. Next. But it's only obvious when it's more severe. That's why only half of affected individuals are diagnosed in a clinical setting. Next. Detection is improved by the use of screening tools. Nobody disputes this. This has been proven again and again. Next. But the U.S. Preventive Services Task Force, that is highly influential in determining what health systems are going to do in terms of practice, they do not endorse universal screening of older adults. Why is that? It's not because screens don't help. It's because no studies have actually asked the question of whether screening to detect dementia changes clinical decisions or clinical outcomes. These would be extremely difficult studies to do, and it's kind of like the snake biting its own tail. If a healthcare system doesn't screen, then they cannot generate any data on outcomes. And they won't screen unless the US Preventive Services Task Force says screen. So the argument is not about the importance of detection, it's really about how to get there. Next. It's important to realize that federal legislation, however, does support early detection. The BOLD Act of 2018 directed the Centers for Disease Control to establish a public health center of excellence on early detection of dementia. That's the center that I co-lead with Dr. Joshua Chodosh at NYU. BOLD stands for Building Our Largest Dementia Infrastructure. This is a revolutionary piece of legislation that is receiving increasing amounts of money to develop more and more kinds of services for people and to promote a public health approach to dementia. Part of what I want to do and am doing with our center is establishing a relationship with the GWEPs or the GWEPs, because you are the people who are transmitting this specialized knowledge into community practice. And that is a dissemination pathway that's very, very important for this detection work, as well as for prevention and healthy brain initiatives. Next, please. Turning now to the Medicare annual wellness visit, this is a CMS benefit that many of you know about. It is a voluntary benefit. Patients don't pay for it. It's paid for, a health system or a doctor is paid to do it, but the patient has no copay. The wellness visit requires detection of any cognitive impairment, but currently does not require the use of any objective method of detecting impairment. There's new pending legislation to require the use of an objective tool, but that is not in place at this time. Next. So, screening for dementia. Yes. In your practice, you have to think about a tool. What kinds of tools are what you can use in your practice? You need to develop a workflow. You have to clarify whose responsibility it is, set those roles and train the staff to do it, and monitor quality. So this is if you decide you want to establish a formal program of screening for dementia detection. So in the practice, those are the steps you need to go through. Next. With your patient, you have to start the conversation. Brain health matters. You'll see a video in a minute about how to do that. You need to normalize the process. This is just part of geriatric care. You know, the checkup from the neck up, as you'll hear on the video. You need to clarify expectations. This is a screening test. This is not a diagnosis. We'll talk about what it means after you've been screened. Need to provide the results to the person with understandable, simple language. And then you need to do something with the information. There's no point in screening for detection if you don't do anything with the information. So you need to schedule an appropriate follow-up and include the family in that. Certainly when a screen is positive, I also believe, this is my personal belief, that healthcare really is a family affair, whether dementia is present or not. And it's just good practice to engage family in care whenever you can. Next. So how do you choose a tool? Well, first you have to think about it and prepare for that. What's your patient population? What languages do they speak? What's their educational level? What proportion are experiencing important social disadvantage? How many have vision impairment or hearing impairment? Why is this important? Well, of course, they may interfere with some cognitive testing, but they add cognitive load. And it makes it harder to process information if you're also processing vision and hearing with difficulty. So these problems can be addressed if recognized, and they shouldn't really interfere by and large with cognitive impairment screening if you address them. So consider anxiety and depression. It's an old saw that depression causes dementia. This is a complicated issue. If we have time, we can talk about that afterward. But the important things are that anxiety and depression, when they're fairly severe, they can interfere with a patient's effort, the ability to pay attention. They can be distracted by their own worries. They may not be able to concentrate well, especially on longer detailed tests. And there are some proxy screeners that I'll get to those in a minute, that include changes that are directly caused by mood disorder. So there is some overlap, but the problem is generally less of an issue than you might think. Consider the practice context. Screeners need to be brief and accessible and easy to score if they're going to be used widely in any kind of a practice, be it a community service practice or a clinical practice. Next. After you prepare, let's look at how to do it. Next. You can screen the patient. Here are some examples. We have many screening tests that are effective. The mini-cog is the shortest of the well-validated tests and the most widely evaluated. The memory impairment screen, the SLUMS, the St. Louis University Memory Screen. This one is longer. These are examples from very short to longer of tests that you can give to the patient. Next. But you can also ask the care partner. This is proxy screening or function-based screening. So the functional activities questionnaire, which has been around for a couple of decades, the informant questionnaire on cognitive decline in the elderly, or the IQ code, a newer version built on the thinking of the IQ code is the AD8, 8 questions about Alzheimer's. Using both types, screening the patient and asking the care partner, builds understanding, engages the patient and family as partners with you, and improves the accuracy and meaningfulness of the process of screening. So I always recommend that screening the patient goes with screening through the care partner because of these clinical benefits. Next. I'm just going to run through very quickly. You'll have the slides, you can see all these. I just want you to know this is what some of them look like. This is the mini-cog. Next. Here's the memory impairment screen. Next. Here's the SLUMS. Next. Here's the functional activities questionnaire. This is one that I particularly like because I think that it tends to be more generalizable across populations. It still doesn't work for those populations. It won't work for non-literate people very well. If they've never written anything, they're not going to be paying bills or balancing a checkbook or putting tax records together or reading a book. Next. Here's a short IQ code. This really compares how a person is doing today with how they were doing about 10 years ago. So it looks for very long-term decline. Next. And then here is the AD8. It's getting a lot of use these days. It's a very good tool also, another proxy tool. It's been used to some degree as a direct screener for patients. It works in a memory clinic setting, but I don't think we know how well it works in a general unselected setting yet. Next. So let's introduce how you do it. I'm going to give you mostly data from mini-cog studies because there are more of them and because mini-cog has been used very flexibly in so many different kinds of settings. So let's try the next one. So now this is the video. So apologies if you have to see an ad, maybe it can be skipped. No,
Hi,
good.
Sam. Nice to see you.
Hey, good to see you.
It's been a while. I think your last visit in the clinic was about 6 months ago or so.
You're right.
Yeah.
Right.
Well, I hear from the nurse that you're here to talk a little bit about some trouble you've been having with your left eye. So I'm glad you came in so we can take a look at that. Before we get started with that, we're doing some new things in the clinic More and more we're looking to prevention. And so when the nurse was in, she was taking your vital signs, looking at the health of your heart and different things. And today we're also going to look at the health of your brain. Okay. We call this our checkup from the neck up. Okay. It just takes a couple of minutes, but requires a little bit of concentration. Sound okay? Okay. The first thing I'm going to do is ask you to listen carefully, because I'm going to give you 3 words that I want you to repeat back to me. Okay. And try to remember them. Okay. The words are leader, season, and table. Can you say those back to me?
Leader, Caesar, and table.
The second word is season, like the changings of the season.
Season, and table.
Right, you got it.
Leader, season, and table.
You got it. Now, Sam, what I want you to do in this circle is make a clock for me. First, by putting in all the numbers where they go.
All right.
Okay?
Well, the way I would do it, I put 12 first, 6, 3, and 9, and then try to figure it out from there. I put it in the center circle, and I need to put 1, 2, 4, 5, 7, 8, 10, and 11.
Okay, now Sam.
I'm at your disposal.
Yep, now I want you to set the time. So it says 10 past 11.
All right, 10 past 11. Well, first of all, I have to go to 10 past 11. So I'll go to 10 with a small arm. And I'll go to 11 with a long arm.
Okay. Okay.
But
no, that's good. You're done with that now.
okay.
Now, I'm wondering if you can tell me what those 3 words were that I asked you to remember earlier.
Wow, that's a good question. You really pulled that one on me. All right, I can't remember all 3 of them.
Okay, can you remember any of them?
No, I can't.
Okay, that's okay. Sam, have you been noticing any changes in your memory recently?
Yes, I have.
Yeah.
No.
Okay. Well, I'm glad that we're talking about it.
Well,
then.
one of them was season.
Season.
Yep.
You got it.
Because I mistook it with Caesar.
That's right. Yeah, exactly.
Yeah.
Well, I'm glad that we're having this conversation. Maybe what we can do is we'll take a look at your eye, which is why you came in. But before you leave, I'd like to schedule another appointment for you to come back so we can talk a little bit more about how your memory has been.
Beautiful.
Does that sound okay?
That's fine.
Okay.
Okay, great. That's an illustration of a very nice way of doing this, introducing what it's about and working through it and being supportive of the individual while you're doing it. Okay, so one of the really surprising and interesting things about screening is that a poor score on a screening test helps to identify people who are at high risk for exactly the same poor health outcomes as a dementia diagnosis. That may seem obvious, but it isn't obvious in healthcare systems. So what does this really mean? It means that a screen alone gives you a lot of information about what the patient might be up against in terms of what you need to start to pay attention to. It doesn't substitute for a diagnostic evaluation by any means, but it gives you a hint that you've got somebody who's at high risk for poor outcomes. And just run through these quickly, one after another. All of these have been shown by one or another group to be associated with failing the minicog, a 2 to 3 minute screener. That's big power. And I think it's really important to kind of simplify your thinking about this, that we have to start somewhere, and starting with something really simple that has the kind of power to kind of show you who might be at risk for any of these complications. That's important to take note of. I want to dwell just a moment on low health literacy. What I mean by that here is low health literacy as it affects the way healthcare is delivered. That this identifies people who have trouble understanding healthcare advice, prescriptions, how to maintain their health, other kinds of health related conditions. That's what I mean by low health literacy here. It's not just they may have trouble reading a document, but they may not be able to understand or recall what exactly you're trying to accomplish in their care. Next. So here are some other findings. This one really showed that failing the mini-cog occurred in about almost a quarter, a fifth to a quarter of people in the hospital for heart failure. And failing the mini-cog was the dominant predictor of bad outcome after a heart failure admission. That includes death or first readmission and a whole host of other kinds of complications. This was an astonishing finding that, that really serves to illustrate what I was saying in the last slide and previously, that a simple cognitive screener can point the way toward identifying a high-risk population of individuals who need extra care. Next. So how about perioperative neurocognitive decline? A group at University of Southern California has done an important study on this. They've started screening all of their preoperative patients. They happen to use the mini-cog because of its brevity and performance characteristics. So they're screening all their patients for cognitive impairment, and then they're going through a much more detailed evaluation. This builds on the advice and guidelines from surgical and anesthesia groups that recommend simple preoperative cognitive screening. They want to provide expert interprofessional management for at-risk patients. Why? Because neurocognitive complications are the most important complications of surgery in older adults. There are many others, of course, but this is one that we haven't been able to tackle successfully, unlike many of the others. So the goal here is to test the feasibility of routine screening in a busy preoperative assessment clinic and to establish a clinical pathway for at-risk older people. Next. What they found was that about a fifth were impaired using the mini-cog, but after an anesthesiologist evaluated each individual patient, they only picked up cognitive impairment in about half of those. How accurate was the mini-cog? Well, when it was used with its typical dementia cut score, that's what it detected, about 21% impaired. The rest of the sample was also evaluated by an occupational therapist and others to detect more subtle cognitive impairment, and that was detected in some people who passed the mini-cog, leading to the decision to use a higher cut score as a failure score for the mini-cog to pick up the great majority of those who are importantly impaired. Then an interprofessional team designed a clinical pathway with the goal to reduce postoperative cognitive decline. Next, please. Though there are no results yet from this study, this is an example. This is the interprofessional team they created, starting with the patient at the center and including surgery, anesthesiology, pharmacy, family medicine and geriatrics, nursing, internal medicine, data analytics, health systems innovation group, volunteers, occupational therapy. And so this is interprofessional teamwork writ large, isn't it? So they set up a design for their team and a time trajectory for developing it. And over the next few years, we're going to see some results from this study as to have they been successful in reducing postoperative cognitive decline using this systematic method starting at the beginning. Next, please. So You have to start with a why. If you want to do screening, why do you want to do it? We've talked about that in many ways just now. And here's the how. Next. Choose the tools, plan your workflow, clarify responsibilities, set roles and train your staff, and monitor quality. We've seen this one before. Next. And with your patient, start the conversation, ask about it, ask about whether they've had any concerns about their memory or thinking or being able to do things in everyday life. Make it part of your normal work. Don't make it something extra or special. It's just part of health. Clarify expectations. This is a screening test, not a diagnosis. Talk about the results and what they might mean, and then schedule follow-up to discuss also with family. Next, please. This is repetition of what we've seen before. What approach fits your patient, your practice, your setting? Are you comfortable doing the initial evaluation? Do you have easy access to cognitive disorder specialists? If so, have you agreed on who you should send? If not, what can you do about that? Have you considered or already put in place a care management program, which is really the linchpin of caring for people with dementia over their life course? And are you in your system moving toward value-based care, or are you already there? Because you have certain options and certain limits based on that. Next, please. I'm going to go quickly through these benefits. This is just to illustrate things that most of you probably already know about. But I want to highlight the 3 benefits that Medicare currently has in place that enable improvement in dementia detection and care if they are utilized. None of them is required, but all of them contribute to better care. So the first is the annual wellness visit in which dementia can be detected. The second is a more detailed assessment and care planning visit. That's the dementia evaluation. And the third is the chronic care management codes, which provide the continuity of care on which good dementia management over time absolutely depends. Without continuity, we don't have value. Next, please. So it's been controversial as to whether the annual wellness visit does improve dementia detection. There was one study published that said it did not. This study that I'm showing you here said that it did, and I think the difference was really one of methodology. So this study used a unique approach to their design. They picked counties where providers liked using the Welcome to Medicare visit. So counties where providers commonly did use the Welcome to Medicare visit, which all Medicare enrollees are eligible for at the point of enrollment. That controlled for provider willingness to use benefits that Medicare allows. So then they looked at, they thought that providers who use the Welcome to Medicare visit were likely to use the annual wellness visit, and that was true. And when they did so, it increased the likelihood of a new dementia diagnosis within 6 months, in whites by a factor of over 2, for African Americans, about the same, for Asian Americans, almost 5, and for Latinx individuals, over 6-fold increase in detection. This kind of approach has immense promise for redressing the inequities in dementia detection and care. It's just a start. Next, please. The uptake is pretty good, but not good enough. The annual wellness visit, only 32+%. Cognitive assessment and care planning, less than 1% in 2019. And chronic care management, 6.7% in 2019 for people with dementia. That's kind of sad. We're really hoping that those numbers are going to start to pick up. Next, please. So how do you do it as part of routine care? Next, please. This is my last formal slide. I want to tell you a story after this. But this is a clinical pathway. It's an implementation roadmap that we developed to try to synthesize all this information so it would be practically usable. And you can see how it flows from detection. I'll focus for just a moment on the detection piece. You can screen during the annual wellness visit or any other visit or in the hospital, or you can elicit clinical concern. Is the patient, the family, or is the provider worried, or anyone in the staff worried about the person's cognition? Are there any hints? When you think back to that video, there were quite a few hints that Sam would probably not do well on his cognitive screening tests. He was slow, he seemed a bit confused, he had early problems with just getting the words into his mind that he was supposed to remember, and he made a very classical error in clock drawing. And then after the fact, he said he was concerned when he was asked. I like to start by asking the question, are you concerned? Have you had any worries? Or has anybody in your life told you that they have concerns about your memory or thinking? Then you work to engage, then you do a brain health evaluation, and how that's done is unique to each setting. But here are the components that we think are crucial. And who are the active participants? Well, a primary care provider, a dementia care team, which in many systems could be a social worker and a nurse working together. There can be other configurations like that, but the dementia care team is, we think of that as not an MD process. There's a physician involved, there's a support team who will generate a lot of the detailed information, and the patient and the care partner, all active participants in care. Leading to a full cognitive assessment and care plan visit, and then ongoing management and care coordination, which is where chronic care management comes in. Next, please. Now I want to tell you a story. I want to tell you about Mary Brown. She was 79 when she came to me. Oh gosh, it's been about 10 years now. African-American woman who had come north to Seattle as part of the Great Migration. She was brought in by her son on referral from the hospital. She'd been in the hospital for severe constipation. I don't think she'd had a bowel movement for maybe 10 days, and she was profoundly dehydrated. They hydrated her, they got her bowels working again, and she didn't really interact much with the staff, and they concluded that she was demented. And so they sent her to the memory clinic at University of Washington, where I saw her. Mary sat in her chair looking down. Her son was very concerned, very kind and very concerned. Didn't want to speak for his mother, but his mother really didn't speak to me. I invited her to tell me something about herself. She couldn't speak. She kept looking down. Then I began to ask her son about how she'd been doing. Had she lost any weight? Well, she'd lost a few pounds. Was she eating? Well, yeah, she was, but not very much. She kind of picked at her food. Was she cooking? Oh yeah, she was still cooking her own meals. Did she shop? Yeah, she would go to the store. It was close by. She could walk and she'd pick up a few things, but she just didn't seem to have any more energy. She was just out of energy. Well, what does she do every day? I asked. She said, well, she sits all day. She sits, she reads the Bible. And I said, well, what does she read? What does she like when she reads the Bible? Well, she likes to read the 23rd Psalm. Oh, and she just keeps reading it all day, over and over. And so luckily, I knew the 23rd Psalm, and I began to recite it to her. At the point at which, maybe after the first couple of lines, I asked her if she'd like to join me. She joined me, and she began to say it with me, and we got all the way through. She looked up and she smiled a little bit. Now, she had been believed to be demented and to have the kind of not rare complications that some people with more advanced dementia have. They get dehydrated easily, they get constipated, they get into the hospital before anybody notices. Was this woman demented? Should I have given her a cognitive screen, or did I actually give her a cognitive screen of sorts? I did, kind of. I screened her through her son a little bit informally. Given her history of being part of the Great Migration and avoiding medical care, which I didn't mention before, coming to the big white university setting, I didn't want to make her feel in any way that she was being objectified, treated like a non-person. She was already behaving almost like a non-person in the office until we got to the 23rd Psalm. She knew it all, she knew it by heart. And once we made that connection, it was possible to determine that she didn't have dementia. What she had was a very rare, but very classical, severe psychomotor retarded late life depression. That's the kind of depression that really interferes with cognitive testing. And so, long story short, she was willing eventually to accept electroconvulsive therapy, a very effective, the most effective treatment for that condition. She responded quite well. Her function was largely restored, though not to full normalcy. She still needed help with many things. She had some mild cognitive deficits for sure, but she was maintained for several years by regular spaced ECT treatments and enabled to return to a large extent to her normal life. So that's an example where you don't want to do cognitive screening. You want to think and feel before you test.